Yeah, this is a great session. Thank you, everyone, for being here, and to the organizing committee for the invitation. It's a nice progression, this particular session, how to get access, get your guides in, which guides to choose, wires, microcatheters, et cetera. But at some point, we got to put in a stent, right? So I'm going to talk a little bit about some techniques and tricks on how to get stents in difficult situations. I think this is probably the best way. Any questions? Good. No, obviously an externalized wire is an incredible rail to deliver a stent. However, not always necessary. So, sometimes we run into situations like this, a very tortuous calcified LAD, and those that are savvy are looking at that right coronary. You see that's very tortuous and calcified as well, even without taking a picture of it. But the caudal shot really shows you how tortuous this LAD is, and hopefully everyone can appreciate the calcification. Here's the right coronary artery. So what are some of the challenges to stent delivery? As I mentioned, I think tortuosity and calcification are the two main challenges that we're facing now. Some fibrotic lesions can be addressed with good vessel preparation. Previously existing stents, whether they were underexpanded, malopposed, et cetera, tend to pose significant challenges as well. Long lesions and suboptimal guide support, and you guys heard about some of the techniques to optimize guide support as well as guide extension catheters, so I'll kind of cover some of that as well. Guide support, very important. We talked about coaxiality being of utmost importance. Also good back wall support, so you can see the difference. Dr. Toma showed the difference between passive and active support with a guide like a JR4 versus something like an AL1, which you can see here on the left side. Same with the left coronary system. You want a guide that, it may not always be the biggest curve that provides you the best support, but one that provides coaxial alignment and good back wall support, as you see on the image to the right there. This is a cute little study that was done and published a few years back on push force. So they looked at guide size, so French size of the guide, and the differences in push force you can attain. You can see that between a 6 French guide and 8 French guide, you almost get 3 times the push force. So there is something to be said about that. I realize that we do most things radial now with 7 French guides. You do get significant improvement in your push force with the 7 French guide versus 5 or 6 French guide. So the first and probably the most simple way to, if you're having trouble delivering a stent, is to use a buddy wire. We've talked a little bit about that. It's simple, cheap. Almost everyone has another wire available in their lab, so that's usually not an issue. Pretty low risk in general. This was a case actually that we did last week on a proximal LAD calcified lesion with some tortuosity there, where a buddy wire helped just get the stent across the distal aspect of the lesion and got a nice result there. Appropriate vessel preparation, I think, is of utmost importance. So again, going back to the case that I started with, calcified tortuous LAD, here we performed orbital atherectomy in the mid-vessel, and were able to easily deliver a stent there and had an adequate result there. This is another case of a heavily calcified, not so tortuous, but really heavily calcified right coronary artery. Obviously, you can see the guide's not even engaged in this case. It was a little difficult to engage, so we free-wired it and were able to suck in the guide after that, and I'll show you the result. Obviously, the LAD is heavily diseased, tortuous, and calcified as well. Again, the two major challenges. So the right was rotated, a proximal stent and a mid-vessel stent replaced, and ultimately we got a good result there. And then flipped over to the left side. Again, rotational atherectomy and a couple of stents in the prox LAD provided for a good result there. So vessel preparation is, I think, of utmost importance when you're talking about stent delivery. It's pointless to sit there and try to jam 14 balloons in a calcified tortuous vessel. If you've had trouble getting your balloon in, your stent's going to be 10 times as hard to get in. So prepare the vessel appropriately for ultimate stenting. Again, Catalin talked about the benefits of guide extensions. This is, again, the same group that showed the increased push force you can attain by intubating your guide extension deep into the vessel. And I'll go through some case examples of that. So again, back to that tortuous calcified right coronary artery, you can see we intubated the guide using a balloon-assisted tracking method to the distal right coronary artery, and we're able to deliver a stent and attain a good result there. So again, safety is of utmost importance. You may need to even limit your injections once you're in that deep. So be careful, and obviously you want to take a final picture once the guide extension is out to make sure you don't have a more proximal dissection before you remove your guide wire. Navigating proximal tortuosity, this is another great use of the guide extension catheter. So here this is a retroflex circumflex in a post-CABG patient. You can see getting that guide extension up and around into the proximal aspect of that circumflex, even though it doesn't extend deeply into the vessel so you can unsheath your stent, it will get you support enough to get the stent down, and that was certainly the case in this case example here, where we got a nice result in the proximal circumflex. And then what about in-lesion tortuosity? So I mentioned, calcification tortuosity. Certainly proximally that can affect your ability to deliver a distal stent, but what about if you have that problem within the lesion itself? So this is a heavily calcified, extremely tortuous right coronary artery, and really the solution to approach this is deep guide extension catheter intubation. Here we also had a buddy wire along that guide extension catheter, and then the use of short stents. So, we have 38 millimeter stents in the US, I think 48 millimeter stents outside the US. You can't always use those. And in these types of situations, although it's not ideal to put in overlapping stents, sometimes that's the only way out of that situation. So this was our final result in this particular case, where we put in, I think, 4 15 to 18 millimeter stents. And then navigating through prior stents. So again, this is an example of the balloon-assisted tracking, deeply intubating the guide extension catheter into the previously existing stents in order to deploy your distal stent. The wiggle wire was also mentioned. I love this wire. We talked about getting a microcatheter down and then switching for a safe wire. Usually if I get a microcatheter down, this is the wire I switch to. What's nice is you can put in a short one and pull your microcatheter, usually without even having to use the hydraulic method of removal. But the wiggle wire is nice because, as mentioned, you can deflect it off the vessel wall, whether it's calcification, tortuosity, or previously existing stents, allowing you to deliver your stent. And this was an example actually from last week on a patient with multiple LAD stents in the past with ISR, in whom we were able to get a wiggle wire down, navigate through those stents, balloon with a cutting balloon, and then ultimately deliver another focal stent and stent the proximal LAD as well with a good result. I will caution, it's July, so it's probably a good time to talk about this, as I mentioned before, but a lot of us tend to try to wiggle stents and balloons down a vessel when we have decent support, but that's kind of the final maneuver where you're kind of jamming. And this was something that we experienced a couple of years back. So this is a patient with cardiomyopathy and a defibrillator. Our wire was very close to that shock lead, and as we were wiggling, trying to get this balloon down in this situation, the shock lead sensed an arrhythmia and fired, and the patient experienced a shock, and we were a little bit shocked too. But in any case, be careful when you do that, all right? So in summary, optimize your guide support, get stents down, appropriate vessel preparation is important. Use a buddy wire, simple, easy, cheap, and widely available. Wiggle wires are great for this particular use. Guide extension catheters, shorter stents, and I didn't show any case examples, but an anchor balloon technique is also a great way to get stents down when you're having trouble delivering. Thank you.
A great series of cases. Any other comments?
Yeah, I would like to mention about the fibrotic lesions you mentioned. Sometimes laser is also a good idea to prep those lesions, especially in stent, and we've had pretty good results with that.
Yeah, no, absolutely. I think that certainly fits under the umbrella of vessel preparation. So in stent, that's a great point. In stent, laser is a great way of vessel preparation.
Yeah, for under expansion. Primarily, but I think the main point, and he made it, but especially for the fellows to remember, is that our stents are so good now that they often deliver. But if you have not prepped the vessel adequately, then delivery is actually a problem. Because if you deliver it and then underexpand it, it's a worse situation than not having delivered it at all. So just something to remember, and that's why he emphasized prep.
Yeah, and that's an excellent point. And with the imaging now, with even OCT, I mean, using it sometimes to help you to make sure your vessel is adequately prepared, because it's going to save you some headaches and also help with decreased in-stent restenosis long term. The one thing just to mention is I saw a couple of the, by the way, great presentation.
Thank you.
A couple of the cases where it looked like it was long, sheaths, femoral, and I totally agree. I like that slide where you showed 7/8 French, you have more pushability, and if there's any tortuosity in the iliac aorta, I say go femoral, long sheath, and use 7/8 French. You know, we don't use 7 French sheaths from the radial approach anymore. We had a case where it was a 7 French sheath to get the 7 French guide to get more support, and the radial artery came out with the sheath. So if we go 7 French, we'll go sheathless and just go with the guide, or just go femoral.
That's interesting. I mean, we routinely use 6/7 slenders with sheaths up, but balloon-assisted track it or track it over a multi-purpose. I haven't seemed to have any issues. Anna, what do you say?
Mitul, can you comment on atherectomy through guideline extension catheters?
Yeah, so that's a little bit tricky, right? I think I believe you need at least an 8 French guide extension catheter to get a 1.5 burr through.
Even a 1.25. Yeah, for roto you need an 8 French guide extender, and for CSI you can actually do it through a 6.
You can through a 6, yeah.
Yeah, so that's actually a great point, because sometimes you do need that extra support to prepare your vessel, and vessel preparation is I think Dwayne's going to talk next about vessel preparation, so you guys are going to learn a lot more about that shortly.
Just have maybe a quick question for the panel or you. All the tortuosity you're showing, and we're seeing a lot of tortuous cases, and the stents have all gotten so good, as you mentioned. What about if you have a very tortuous segment, are you a little more likely to add a little extra length to your stent? And do you think one type of stent is necessarily better at not straightening out the vessel and maybe causing a pseudo lesion on the edge of the stent? Or what do you do to help manage those things? Yeah,
I think the point is, you don't want to leave your stent edges in a tortuous segment where you could end with an edge dissection, or a further downstream issue with edge restenosis. So yes, I do use longer stents and try to keep the edges in straighter segments. I like to think that there's a difference, but in terms of your second part of your question, the stent manufacturer, and do some accommodate tortuosity better? Obviously the thin strut stents do, I feel like, accommodate the tortuosity a bit better. There may be a cost to pay in terms of your radial strength, but typically in those situations I will go for something like Suryo or Synergy, something like that.
Okay. I've had colleagues bend stents outside the body before inserting. Any experience on the panel with shaping your stent ex vivo before putting it in?
I think it has the same effectiveness as like saying a Hail Mary or like doing.
The one thing I'll say, the one thing about that, so we inadvertently sometimes can bend stents in vivo, right? So if we're pulling a stent back that doesn't deliver, either through a guideline or through the edge of the guide, if you're not coaxial, you'll actually kink the stent. And actually, so one thing I'll suggest, and I'm sure that everyone on this panel has had this happen to them, is that when you pull the stent out, look at the stent before you put it back in, because a lot of times you'll see struts that come off, you'll see something that failed. That's a surefire way of losing a stent if you try to put that back in, and it may not even go in. So just something to keep in the back of your head.
I think one other thing that's worth talking about, especially for fellows, is that you can change several things. You can change where the wire is, and that sometimes changes the bias by pulling it back or pushing it forward. But the other thing, especially from the radial, it's more important, is you can change the angulation of the guide. Sometimes if you come down and up versus going up and down, you just get off a spicule of calcium, and so that plus breath holds are easy tricks when the fellow is really, really struggling, and then one of us kind of walks in and we just bang deliver the stent. That's the trick. So it's not anything special, but that's kind of what we're doing.
Yeah, no, that's a great point. Sometimes for those circ lesions, you walk in after someone's been struggling for a while, you just pull the guideline, or not the guideline, or the guide up a little bit, and it gives you a better angle, and you feel like a hero, and you walk out of there. So it's kind of.
And then they ask how you did that, and you said, well, I'm the attending.
Yeah, exactly, yeah. I'll tell you later. Thank you.